Hi, good morning, Monique.
Good morning. How are you?
Good. How are you doing?
I'm doing well.
Good. I'm glad you made it.
Yes.
Good morning, Cleo.
Hello.
Hey,
Hi, Cleo. Good morning.
we're just going to give it a couple more minutes, allow some more people to come. So today's our first non-summer day, huh? It's September 1st, but I feel like it's like October 20th right now with this weather, you know?
I can't wait for it because I'm born in the summer, but I can't take the heat.
No, I totally hear you.
Good morning, everyone. Well, afternoon, sorry.
Yes, now, right?
Good afternoon, Cleopatra. Speaking of October, Cleo, isn't your birthday in October?
Yep. I can't wait.
October what, Cleo?
12.
Oh, nice.
Very nice.
When is your birthday, Monique?
Oh, June 25th.
Oh, okay.
So what does that make you, Monique?
What
What
they
sign?
say?
What
They
sign?
say a Cancer.
Okay. Hmm.
Good.
Good morning.
That's my son. He was dying to say good morning.
Oh, good morning.
Good morning. Good morning, Chanel. It looks like Rory's joining us. Good morning, Rory.
Morning, Rory.
Good morning, Markia.
Good morning. How are you?
Good. How's it going?
It's okay. It's going good.
Good.
Yeah, no complaints.
Good morning, Reginald.
Good morning. How are you?
Good. How are you doing?
Not bad at all. I just saw this, so I just decided to click on it.
That's a pop on. Good. I'm glad you did.
Yeah.
I'm gonna give it a couple more minutes. We should have a couple more people joining us. Hey, Velma. Hi, Virgelma. How are you?
I'm doing good. Thank you for asking.
Good. Okay. So today we are going to talk about safety and risk assessment and planning. This was created, and I'm creating a series of trainings for all the therapists within the practice. So those that are within either side of the practice, the male division, the female division, and I've also invited some new people who are going to be joining us, as well as some students who are going to be joining us for the year. So I think this will be great. And again, this will be available in everyone's supervision groups. Okay, so I'm going to share my screen and I'm going to pull up my slideshow. Okay, I'm just gonna move this over a bit. Okay, can you all see this? Can you see the slideshow?
Yeah.
Yes.
Okay, terrific. Okay, so again, good morning. My name is Amira Martin. I'm a licensed clinical social worker. You may know me as Amira Crawford, but I have changed my name, and my legal name is Amira Martin, okay? The legal name of the company is MA Therapy LLC. We have a couple of DBAs for different divisions and some of the different work that we're doing. This is our number. And if you would like to, you can go on AmiraCrawfordTherapist.com and you'll see a lot of the information about the 3 divisions that we have, okay? So welcome. So today, we're gonna cover a few things, right? We're looking at safety and risk. And we're doing this for a couple of reasons, and we're going to talk about those reasons, right? So first, we're going to look at why. Why should you assess for safety and risk? Number 2, when should you assess for safety and risk? Number 3, how do you assess for safety and risk? And 4, we're going to actually look at safety planning and what that entails. Then we're going to talk about supervision and safety planning. And finally, the safety plan and documentation, okay? So why should you assess for safety and risk, right? First of all, you should do it because it's a norm within mental health practice. As a mental health practitioner, you're consistently coming across people who are dealing with crises. And those crises may be life-threatening for some of them. They may become suicidal. They may become homicidal. There are even times where people become psychotic, and that could be a temporary state or part of a longer illness. But it is a norm to assess, for safety and risk with our client population on a regular basis. We especially want to be thinking about this now, right? Pre and post COVID times, right? We're dealing with a global pandemic. What do we know? We know that during global pandemics, suicidality rates usually increase during, and at the very least after the pandemic. We know that we're going to have more mental health issues with the special populations that we deal with during and post this crisis, right? And also we know that the possibility of suicide goes up during times of stress, right? So during serious economic problems in a country, during war, and during other crises. So we're dealing with a multitude of these issues right now, right? Now, when should you complete a safety and risk assessment? So you're working with your client day to day, right? You have your weekly or bi-weekly scheduled appointments. You're going to be thinking about a few things, right? You're going to be listening for statements in general. This is something you're generally going to be doing and working into the way that you work with clients, right? So listening for statements that speak to being either actively or passively suicidal, right? So is the client saying things like, I just don't want to be here anymore, right? That's what you would consider a passive suicidal statement, right? Or saying things like, I'm going to kill myself, right? That's an active suicidal statement, right? So you want to be listening for these sorts of things. Is there any mention or any statement about, I don't want to be around, or I don't want to be alive, right? You're going to be looking at the evaluation that you completed. Does this person have a history of serious mental health issues, of major depression, bipolar disorder, schizophrenia? Have they completed or attempted an attempt of suicide in the past? Are they dealing with any significant stressors, right? Did they just lose someone that they loved? Did they just have a recent breakup? Did something happen that would significantly make it more hard for them to function day to day? You want to pay attention to anniversaries or times of year that have been significantly painful or traumatic for this person, right? So the anniversary of the death of their dad, for example, the anniversary of the death of their wife. If they were a victim of a serious traumatic event, you want to be paying attention. When did that traumatic event happen, right? Are we nearing that time this year that this happened to you a year ago, or 2, or even 3, or even further, right? You want to be paying attention to that. One of the things that I think is really important to talk a little bit about, it's like prior pandemics, right? We know that there were increases in suicide rates during the Spanish flu in the US, the Spanish flu of 1918. We know that during the SARS outbreak, right, in 2003, we know the Ebola pandemic in Africa, there was increase in suicide rate. And why? Increase in isolation, right? People are isolated and they're staying apart because they don't want to get sick. Increase in fear and worry about getting sick, or what's going to happen to their economic situation or their housing situation. people are more marginalized and separated from the communities that they're normally part of. Just economic stress and unemployment, right, which we've seen plenty of. And the protective factors go down, right? There's a decrease in things that would protect us normally from the possibility of suicide, right? So less attendance at religious events or none, less time with family, less time with friends, less time with extended family. Those are all things that contribute, right, to suicide and an increase in suicide rates. And we're dealing, again, with most of these things now. So there are special populations that are at an even higher risk currently, right? And so I want you to keep this somewhere in the back of your head, just know it so that you know you're aware. So people who are elderly, again, because they're isolated, people of color, right? Just dealing with the stress of being a person of color and some of the differences in access, the differences in education and support, right? Dealing with racism, right? Those things make your risk even higher. The unemployed, those who are mentally ill, and also healthcare workers. So those are some of the people and situations that, we always want to be thinking about in general in terms of risk. Next, I'm just going to try to turn this here. Okay, so now you don't have to figure out active versus passive suicidal ideation, right? You don't have to, figure out the details of what your client is saying. But there are three things to think about. And this is sort of how we measure the severity or the seriousness of a suicide risk. Every time a client mentions suicide, it's to be taken seriously, right? But just for your own information and your own, do I have time to call my supervisor and talk this through and just do a safety plan with this person and follow up and maybe have them see their doctor versus should I be calling 911, right? There's a difference in that. So I'm going to walk you through some of what you might be thinking about and figuring those things out. So first you want to think about these three questions, right? Suicidal ideation, suicidal intent, suicidal plan, and then means, right? But means is less important than the other three. So with suicidal ideation, it's an idea, right? Does this person have an idea that they want to commit suicide or that they don't want to be here anymore? Have they stated anything to give you that idea? When you ask them, are you feeling suicidal? I've thought about it. That is, yes, positive for suicidal ideation, okay? Then you want to think about intent. Are they saying that they're going to do this or that they want to do this? So intent is, are you thinking about suicide? Yes, I've thought about it. Are you going to do it? I plan to at some point versus maybe versus I'm not sure versus no, I could never commit suicide. That would destroy my kids and my family. Right. So you see how we have intent with all of the others except for that last one, because they were saying pretty much, yeah, I'm going to, or maybe I will. And so anything that, is positive or towards yes, and anywhere in that intent question, you're looking at it as yes, they have intent, unless they say, no, I won't because, right? And there's your no intent. Then you want to think about,
again?
I'm sorry, go ahead, Reginald.
Could you explain the ideation part again?
Yeah, absolutely. So suicidal ideation is really just an idea. Do they have the idea of committing suicide? Have they said anything to you like, I don't want to be here anymore. I can't take this anymore. I don't want to be here. Or I'm not going to be alive next week, or, something to give you the sense that they have the idea that they want to commit suicide. And then if you see yes for idea, then you move on in your mind to the next question. Is there the intent, right? Are you going to do it? Do you intend to do it? Yes, maybe, sort of. Those are all yeses for intent. If you hear no, no way, or no because of my family, no because of my friends, no because I have, my session with you next week and I want to make sure that I continue to work on myself, that's a different answer than the other possibles with intent. You want to consider all the other answers yes, unless you get a clear no. And then suicidal plan, right? So they have the ideation or the idea, they have the intent, they actually intend to do it or they might do it, and the plan. So if you ask them, well, have you thought about, and this is how, a really good way to ask them, have you thought about how you would commit suicide? If they say, yes, I have, I'm going to slit my wrist. Yes, I have, I'm going to, run into traffic. Yes, I have, whatever it might be. That's much, much, much more dangerous and risky than if there wasn't a plan, right? So ideation, risk, ideation and intent, even higher risk, ideation, intent, and plan, severe risk, okay? Because getting to an actual plan shows that they're actually at the next step, the planning phase of executing that. It means you might, just so you know, you don't really have to think about means, but is the way that they're going to commit suicide realistic at all, right? Like, I'm going to, do something that wouldn't cause harm to anyone. I'm going to drink 12 Pepsis in a row, like, something, depending on the client and what other issues they're dealing with, you might get an answer where there's absolutely no risk or there's some risk. But as soon as you hear the idea, you want to ask the additional questions. How would you do it? Do you intend to do it? How would you do it? Or have you thought about how you would do it? And so you want to get those 3 answers. And you want to speak to your supervisor, right? Unless they're saying, yes, when I get off this call with you today, I'm going to hang myself. Then you say, okay, hold on. And you call 911, right? Versus, yes, I really want to commit suicide. I don't know if I can take this anymore. Then you do a safety plan with them. You tell them you're going to have to speak with your supervisor. And then you call back and you check on them and you create a plan with them. So we're going to take a look really quickly. Columbia University has an amazing assessment tool that it makes available to the public. So we're going to look at this assessment tool. Let me just see how I can do this properly. Okay. Okay, so this is the tool with Columbia, and I'm going to email this to everyone also. So, and this is just a PDF that you can download right from the website, right? So here are some of the questions that you can ask. But again, if you just ask ideation, intent, and plan, you're fine, right? But this is just going to go a little bit more so that you can learn a little bit more about it. So first, have you ever wished you were dead or wished that you could go to sleep and not wake up, right? So that again speaks to passive ideation, right? Current suicidal thoughts. Have you actually had any thought of killing yourself? Yes or no? Suicidal thoughts with method. No specific plan or intent to act. Have you been thinking about how you might do this, right? Yes or no? Because remember, they're trying to get to that plan part. Suicidal intent without specific plan. Have you had these thoughts and had some intention on acting on them? So they're looking at intent here. Intent with plan. Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? So again, you're looking for a plan and intent, right? Have you ever done anything, started to do anything, or prepared to do anything to end your life? Here are some examples: collected pills, obtained a gun, gave away their valuables, right? We know that when people are suicidal, they may give their valuables away. They may want to make sure that they've kind of cleared up everything that they need to think about. Cut yourself, took pills, held a gun, and changed your mind. They're trying to look at any possibility around a history of suicidality, right? So yes or no to these questions. And if yes, was it in the past 3 months? And here, this is called activating events, right? So these are some of the stressors that we were talking about. So issues with the law, right? Financial issues, relationship issues. Are they dealing with potential incarceration, homelessness? Are they isolated, right? Or are they someone that doesn't have the support that people need, right? Any prior history in terms of treatment of serious mental illness? Are they hopeless or dissatisfied, right? So they're looking at depression there. Are they compliant or not compliant with their treatment? Are they having insomnia, right? We know that, and this insomnia is here, we know insomnia, we know sleeping is very important, right? And that not being able to sleep can exacerbate any sort of underlying mental health issues. That's why it's so important. So we're looking at hopelessness, depression, mood disorders, command hallucinations to hurt oneself. So within the practice that I run, right, we don't really deal with people who are psychotic for the most part or dealing with hallucinations. So we don't really need to think about this much. But there are people who have command hallucinations. So meaning hearing a voice that tells you, kill yourself, right? Physical pain or chronic pain, people who are highly impulsive or addicted to substances. These are all risk factors, some of the stressors that we talked about. So then they're looking at the protective factors, right? Fear of death or dying. So if someone says, yeah, no way, I would never do that. I don't want to die, I'm afraid. Or if they can identify a reason for living. So again, I wouldn't do that because of my family, because of my pastor, because of whatever it may be. The belief that suicide is immoral, high spirituality, family, strong support network, engaged in work and school. These are all some of the really positive things that can be protective. This is just more about the thoughts, right? So again, you can think about ideation, intent, and plan. How many times have you had those thoughts? Obviously, someone who's having those thoughts 5 times a day is much more worrisome than someone who has them less than once a week, right? How long do they last? Are they fleeting? Do they last hours? Very big difference. Can you control yourself and stop thinking about it? Poor impulse control is correlated with a higher suicide rate. So it's something you want to think about. What are the deterrents, right? Again, the protective factors, things that would stop you from doing it. And the reasons for the ideation. I don't really go too much into this whenever I've assessed for suicidality. I feel like we have to really guess a lot, and sometimes people are uncomfortable about some of this, like to get attention, revenge, or reaction. We never want to create the idea with our client that we don't believe them, or that we don't believe that they're in pain, or that they just want a reaction, right? Like another thing that's been studied is the people who feel suicidal and don't carry out suicide versus those who do. And one of the things that we know is it's more of a risk, more danger of actually committing suicide if you say you want to and people don't take you seriously or say, oh, you just want attention. So we don't want to, bring those ideas as a reason. If someone tells you that's why, then that's one thing. But we don't want to bring that forth as like, is this why you did it, just to get attention or revenge? And these are some other reasons, right? To stop pain, to completely end pain, that sort of thing. So now, then they have an actual area where you can go and figure out how high the risk is. I don't really recommend that people necessarily do this. It's really good to look at and to think about. But again, as soon as you have the ideation, you'll want to be talking with your supervisor about it, because you want to make sure that everything goes fine and that you are not minimizing any risk or not putting in a proper plan. Okay, great. So now, yeah.
So I know that our practice don't take on clients that are suicidal, but is this just for, like, say if you have a client that come in for a different presenting issue and then wind up, I don't know, possibly feeling this way and then, okay.
Absolutely, Monique. So, and there may be times someone comes in, even with a mild depression or dealing with anxiety or dealing with a loss, or just to gain insight. And then over the course of time and working with them, they start to deal with some of the other issues and stressors that a lot of people in our communities are dealing with. And then next thing you know, they're presenting with you as suicidal, or they develop a mental health issue that's, worsens gradually over time, and then they're suicidal. So we definitely want to have it in the back of our head just in case,
I have another question. So if that was the case, how would you, because ending sessions, right? We do have to let our clients know to like basically wean them off like it's medication, right? Because some
right.
clients can, they're just not ready. But
You mean like
If-
termination?
termination, that's the word, yes.
Yeah.
So
I mean,
how would you like go about
like terminating.
terminating like at this,
Well, right.
like,
If
that
they're
happen?
right. No, if they're a suicidal client and we've been working with this person and they become suicidal, we'll continue to work with them. We'll see them through the crisis and continue to work with them. We would definitely not, terminate with someone because they became suicidal. We'll work with them. We'll do a safety plan with them. We'll do interventions with them. We'll refer them to a psychiatrist and assess for medication. We'll do all of those, regular clinical things. But if they're coming to us with an extensive history around suicide and currently suicidal, then that's someone that probably would need a higher level of care that we would not take on,
Okay, thank you.
You're welcome. Anybody else or anything else? Any other questions?
Yes, Amira, I was taking notes when you were going over the population with the
Mhm.
elderly, the people of color, mentally ill, and healthcare providers. I feel like I missed one. If you can just repeat the list again.
Yeah. Sure. I'm going to actually pull that up really quickly. Um, okay. Are you able to see the screen? Or do you guys just see me?
No, we could see the screen and you.
Okay.
You on the side. Right.
Okay. So at higher risk, the elderly because of isolation, at higher risk of suicide currently, right? The
I'm
elderly.
sorry, we still see the assessment tool. I don't know if you're showing something else.
No, I'm not.
Okay.
No. So at higher risk, right, is the elderly because they are isolated. Youth, and this might sound odd, but youth, because like there have been so many students who have not been able to go to school, been able to socialize due to COVID, been able to be part of the protective factors and communities that help them. Racial minorities, so people of color, right? Those who are unemployed, those who deal with an underlying mental illness, right, or have a significant mental illness outside of the stress of dealing with what's happening currently, right, and healthcare workers. Does that answer it?
Yes, it was the unemployed that I missed.
Okay, terrific.
All right,
Okay.
thank
So
you.
these are the higher risk people
Yes, currently due to COVID.
currently. Okay.
Yeah.
I have a question, Amira.
Yep.
Yes, I would just like to know if this would be the same thing for, you mentioned about the youth, right? Would the youth includes the elementary students?
Yes. For youth, it includes school-aged youth. So anyone who's school-aged. So 5 and up.
5 and up, okay.
Mhm.
And we will be asking the same question to them directly, or we need the parents?
Yeah, for the youth, you definitely want to ask the youth directly, and you also want to ask the parent about any changes that they've noticed and whether or not you've heard these things from, whether or not the parents heard these things from them.
Okay, thank you.
You're welcome. Yep. Anybody else? Okay, I am going.
Yeah, I have a question, Amira.
Yep.
If we're doing the initial consultation, and then they mention these high risk do we, how do we go about that? Do we refer them to the emergency room or hotline?
Yeah.
suicide-
Yeah, so if you were very high risk and talking about having current suicidal ideation and intent, you would absolutely want to encourage them to go to an emergency room or contact them. They can contact a mobile crisis unit if they're in New York City. And I think also in some other areas in Westchester County and other counties in New York also have mobile crisis units who can actually come to a person's home and do an assessment on them and link them up with medication and a provider that can work with them ongoing, somebody who can handle working with someone who's at that high level of need.
So do we have to follow up on them after the consultation or?
You don't. You have to provide the information. And if you tease out that they might really benefit from you making the call for them, then that's always a wonderful thing to do. But you don't have to do that. We don't have any obligation, but you do want to make sure you provide them with all of the information that they would need. And if they say, can you please, help me make this call, then I think that that's probably a really good thing to do.
Okay, and additional question, Amira. So if we're thinking that we already did all these things, right? And if the client will respond to you that, no, I'm not really interested to call them, is it my job to call for them?
And there is a consultation.
Yeah, during the consultation.
If they have active suicidal ideation, intent, and plan, then you would call 911 for them.
Yeah.
Okay. All right. Thank
By
you.
law, we would legally call the 911 and get an ambulance to help them. Or you could go ahead and call 311, but and ask for a mobile crisis team. But 311 usually wants, the mobile crisis teams usually want the client to be part of that.
Right. And this is our part as mandated reporter.
Right. Mhm.
All right. Thank you very much.
Thank
Yeah.
you.
You're welcome. Mhm. Okay, so Sumithy had a question.
Yes, hi.
Okay,
I feel like I need to introduce myself. Hi, everyone. I'm Sumithy Applewhite. Been here for like a year now. Anyways, so I also wanted to point out that with youth, this could look different because parents need to be involved.
Yes.
And so it's a lot easier with adults because they are adults and they can make decisions. But with youth, you always have to make sure that the parents are involved and that the parents follow through with what you are suggesting, depending on what setting that you're in.
Thank you, Sumithy. Thank you
Right.
for
You're welcome.
mentioning that. Absolutely.
And
Mhm.
this is all breaking that HIPAA, that confidentiality as well,
If you,
right?
right, well, if it's, you mean for the children?
No, just for like the client
general?
period, like,
No, because that's
Think-
the, right,
ahead.
that's one of the areas where we always break it, right? So like in our intro where we talk about the times that I may have to break confidentiality or everything's confidential unless you tell me you're suicidal or homicidal, talk about child abuse that's happening now, your record subpoenaed by the court. Those are times that you have to break confidentiality. And so
Yeah.
that's, a norm, right? Okay, so anyone else? Okay, so do you guys see this screen with questions, ideation, intent, plan means?
No.
No. Okay, so I'm gonna resume the sharing. I'm gonna close this out. Okay, how about now?
Let's see you.
No.
Let me see the group.
Okay. Okay, how about now? Are we back at the screen?
Yeah, we're back to the safety.
Okay, terrific. Thank you. Okay, so safety planning, right? It's always a team approach, right? So you always want it to involve you and your supervisor, right? You want to complete a safety plan. And remember, ideation, intent, plan, those are the questions. You want to complete a safety plan, and we're going to walk through that. you want to always take issues of safety and risk extremely seriously. Again, we don't want to ever minimize that and then have a negative outcome and someone lose their life. So you want to explain to them that this process involves your supervisor, right? Like I know that we work together confidentially, but just like in the introduction, when I first met you, this is an issue of risk and safety, and I'm really concerned for you. So at this point, I really have to involve my supervisor in this discussion, right? So you would ask those questions, you would complete a safety plan with them, then you call your supervisor immediately, right? Unless they tell you, I'm going to commit suicide as soon as you hang up with me, and then you would do something else, right? That's an emergency call. But ideally, you would just be able to call them right back within an hour or so, speak with your supervisor, let them know what's going on. So, and also for those who are in my practice, I'm also available. If your supervisor's not available, first reach out to them. You can always reach out to me, okay? So here we're going to go ahead. We're going to look at a safety plan, and this plan comes from New York City Well. So from the New York City, one of the New York City websites. I'm going to see if we can do it this way. Okay, great. So safety planning guide. What is a safety plan? Well, basically it's like a written out plan, right? So the support that and coping strategies that are going to be used if this person feels suicidal. So what will they do when they start to have these thoughts? How will they cope, distract? Who will they notify? Then you want to think about who will have a copy of the actual plan, right? So the client or the patient will have a copy of the plan. You'll put a copy of the plan in their file and write a note on it, or just write a note detailing the plan. How should it be done? Well, it's a clinical process, right? So you're going to be listening to the client, you're going to be empathizing with them, you're going to be hearing them and engaging them. You want them to identify some of these supports because we want them to use this plan if they should need to, right? And then it talks about there are 6 steps in the development. So we're going to take a look at that. So step 1, the warning signs, right? So we will ask the client to identify what are some of the signs. How will they know that they need to use a safety plan, right? So that might be, well, when I start to think about hurting myself, or when I start to feel hopeless, right? Or when I'm thinking about whatever it may be that speaks to them potentially being suicidal, right? You'll ask them for those warning signs.
Sorry, Amira, to cut you off. Are you sharing something? Or it's just a screen?
Yes, can you see the safety plan or no?
It just says develop a safety plan. Lady smiling.
Yeah, with just the link.
Oh, okay. So let me go back. Thank you, Virjama.
You're welcome.
And thanks, Reginald. Okay, I'm gonna stop this and I'm gonna pull up okay. Okay, can you see the safety plan?
Yes.
6 steps? Okay, wonderful. Okay, great. So how will we know, right? We're going to ask the client, how will you know that we need to use this plan? So we're going to identify on the safety plan, what are the warning signs that they're becoming suicidal? What are some of the things that will start to enter their mind when they start to feel this way, right? What do they experience when they're feeling this way? So thoughts, images, thinking processes, mood, behavior, using their own words. So you'll ask the client and they'll tell you when and what comes up for them, and you'll write it out. So when client feels X, Y, Z, and then the next part, step 2, what they will do. They will, right? So what can they do on their own, right? So for some clients, it can be things like focusing on something external, right? So I'll do my nails, I will color my coloring book, I will write a letter to my sister, I will, whatever it might be. So what are the things that they can do, right, on their own? How likely do they think that they'll use this step if they're in a crisis? What might stand in the way? What other things, what might be the roadblocks, and what else might work if they feel like these things won't work? What will work? What will help them? Listening to music, playing their favorite song, preparing a certain meal that they really enjoy, things that will just help them cope through the moment. We know that obviously that's not going to cure them of suicidality, right? But it's going to help them in the moment feel better. So, and that's what you want, to help give them coping strategies to work through the crisis. Social contacts, right? So who can they call? Who can they talk to? Who can they talk about how they're actually feeling with, right? Is their best friend, their brother, their dad, their sister? Where can they go, right? What are some of the safe places they can go to be around other people where they feel comfortable? They have a favorite coffee shop or place they like to go. List several people in social settings in case the first option is not available. So you want to have multiple options for this person to reach out to. And remember, the goal is distraction, right? So distraction from suicidal thoughts and feelings, they're keeping busy with something else. And again, you want to engage in the likelihood of them, you want to assess the likelihood of them engaging in this step. Identify family members or friends who can offer help. In your family, who do you think would be the most helpful to you in a crisis? Who can you really talk to about how you're feeling? And again, how likely are you to use this? Then you want to think about agencies and professionals, right? So who are the mental health professionals that should be in your safety plan, right? Are there other healthcare providers? So there is going to therapy every week, right? There is, depending on your relationship with the client and your discussion with your supervisor and or with me, whether or not you'll do check-in sessions in between. Do they have a psychiatrist that they're also seeing that they can touch base with and meet with periodically? Are they in a group? Like whatever other providers there are, you want to involve. List names and numbers of clinicians, urgent and local care services, right? So this would be mobile crisis unit. You can, if you're in New York City, you can call, I think it's 311 and get the information on the local mobile crisis team for a person based on their community. So their zip code, their address. You can think about, you can identify for them and with them the local hospital where they could go if they're feeling suicidal and it's at the place where they need to be seen urgently. If there's someone who's on medication, you want to, for depression, you want to have them talk with their psychiatrist, and you want to also touch base with their psychiatrist about what they're experiencing now to see about them either changing meds or increasing meds or doing something differently. If they're not on medication, you want to arrange for them to have a psychiatric assessment, right? We have to take suicide very seriously. This is an incredibly difficult time. So we want to be thinking about that. And this says role play and rehearsal can be useful. What would you say to your doctor? What would you say to your sister? What would you say to your dad when you're feeling this way? Making the environment safe. So when I used to work at North Central Bronx Hospital, I was part of the child crisis team. So we would cover all of the suicidal youth in the emergency room, right? So pediatric suicidal youth. So anyone under 18 who was suicidal, and this was one of the things we used to have to do, right? Make sure the environment was safe. So if it was a teenager who tried to slit their wrists, okay, get all of the knives out of the kitchen and put them in a safe place with a lock and key. Only the parent has the key, right? So you want to think about this with adults. So if you are a suicidal adult, do you have a gun in the home? Can you take knives out of your home, have your sister keep them temporarily? How can we limit your means to access to anything that can actually be lethal for you, right? And again, if this is someone under 18, you're always involving the parent in this entire process, okay? And that is what that looks like. I'm going to, here it is. So this is part of it, a sample safety plan. So when I email you all after this, you'll also get these, right? Um, So you'll be able to look at this. This just walks through what we just talked through, right? So the warning signs that a crisis may be developing. Internal coping strategies, what can they do? A relaxation technique, a physical activity, or anything physical that they can do, anything external that they can do. Who are the people in the social settings that provide a distraction? That these are people in social settings that they want to be in. Who can they ask for help? So who can they really talk to about how they're feeling and what they're dealing with, that they can ask for help? What are the agencies or professionals that they can contact during the crisis? So is there a local hospital? Is it a mobile crisis team? Is it you? Is it their psychiatrist? Is it their medical doctor? Is it multiple? And then some other additional names, clinician name, numbers, urgent care services, a suicide prevention lifeline, okay? And here it says the one thing that is most important to me and worth living for is, again, we want to help them identify and remember why it's important to be here. What do they value and who do they value in terms of that? Okay. Any questions about this? Okay, so I'm going to send this to everyone and I'm going to go back to our slide. All right, so we talked about developing a safety plan. And do you know, this is a therapist, she's laughing. You know why? She successfully completed a safety plan and her client is fine now. So she is thrilled, okay? All right, so always, these are things to always remember, right? Always immediately involve your supervisor. One brain works better than two, especially in assessing risk. If you can't get in touch with your supervisor, if you're on staff with me, you can reach out to me directly, okay? After the preliminary discussion with your supervisor, you wanna provide them an emailed copy or however you can give them a copy of the safety plan. Don't wait, it's very important. You want to make sure that you gave the client a copy of the safety plan. That's key, right? How are they gonna use it if they don't have it? Again, email it to your supervisor and write a note in the chart that you created a safety plan, why you created it, and what the plan entails. And congratulations, you have successfully dealt with an issue of safety and risk. Now you want to make sure that you revisit this concern, right? So they may be suicidal next week, they may not be. You want to revisit, you want to re-explore. How are you feeling? You want to talk about it. And also re-explore with your supervisor that this happened and anything else that might need to occur because this happened, and you want to document all the way. It's very important. It's funny because I got an email yesterday from Healthcare Provider Services Organization where I have my insurance. And they talked about, the email was all about safety. And it was a discussion about a client's family. This client was now deceased. He had committed suicide. He was on antidepressants. He committed suicide. And the reason that his family was suing all of his providers, so his therapist, his psychiatrist, his doctor, was because they didn't coordinate care, because they didn't communicate with one another about his care. So you do want to make sure that you do reach out especially if they're seeing a psychiatrist, they're on medication, you want to have that discussion and you want to document to make sure you two are on the same page with things, okay? So be proud of yourself. You have learned this today and I know you will do great with it. And that is it from my end. So any questions, thoughts, feedback? Okay.
Very informative and I've learned a lot. Really good.
Terrific. Wonderful.
I was going through this discussion with one of my clients, which is a child, but I'm just trying to figure out, I think I was talking about something, I don't know what the topic was, but I was going over what suicidal ideation is compared when the person does the actual act. And I said, that comes first, the thought,
Absolutely.
So whenever you hear someone's committed suicide or whatever, the thought was already, there,
Mhm.
So this just opened up my eyes and gave me a whole lot more information on suicide and what steps we need to take and the whole plan.
Terrific.
I really enjoyed this.
Wonderful, Monique. I'm glad you got some things out of it. That's terrific.
But a safety plan is only done when needed.
Yes. Only when necessary. Yep.
Okay.
I would just like to thank you, Amira, for sharing this information to us. It's very helpful. Actually, we need
You're
this
welcome. My pleasure, Pajalma.
time
You're
to
so
talk.
welcome.
I'm glad I saw.
Amira,
Yep.
you're gonna send us that information?
Yes, Louis. I'm gonna send it out right after we log off. Yep.
Yeah, this was very valuable, and I love it. It's applicable so much in so many different clients. Thank you.
You're welcome. My pleasure.
I'm glad I saw it.
I have something.
Okay, I'll wait.
I think it'd be ethical for us if we follow up on the patient, on the client, because it shows our empathy, and it probably, more value for the client.
Yeah. You mean with the consultations, right?
Not only that, when you follow up,
Yeah,
you
no,
show that
absolutely.
you're really,
Yes.
empathy, stuff like that.
Absolutely, Rory. I'm there with you 100%.
Hey, Amira, this is Tosin. Hi, everyone.
Hey,
Thanks
Tosin.
for this. This was amazing. Just a
You're so
clarification.
welcome. Yeah.
There's a misconception that safety plans are only needed when clients have ideation with a plan, but I usually do one when there's actually just a thought, like, hey, I
Yeah.
felt suicidal. I haven't had a plan. I haven't had any actions, but I have a thought about it. So that way, it kind of alleviates a lot of the stress and it redirects them immediately. So when they do have a thought, even before they have a plan, we can, we are at the ball game.
Yes. Thank you for mentioning that, Tosin. Absolutely.
No problem.
With ideation, you absolutely want to create a safety plan. Any idea around suicide at all, we want to take it very seriously. Thank you, Tosin. Okay. So,
I made one quick question.
yep.
I discussed towards the end about, having a client that had the ideations and had the plan and then eventually followed through with it. I'm asking from the perspective of the person treating the person, like, if that affects you, like, what do you do? You understand? Like, if you've been treating this person for a while and, people who go through that, sometimes it feels like they're turning a corner and then sometimes it comes back, like the back and forth, and then they actually go through with it. How do you just like try to get over that as the person who's treating them?
Yeah. I mean, honestly, Sandy, that is like so incredibly difficult, right? Like, I mean, I've been fortunate, knock on wood, that I haven't had a client, and I hope that I never have that experience and never have to witness anyone go through that, something so painful and the effects it has on their family and community and everyone. But, it is devastating for the clinician. I know some clinicians who have been through that, and they require their own intensive therapy and sometimes even trauma therapy after having a client who commits suicide. So I can't really walk you through what that looks like, but it's just, a really, really difficult time for the therapist, and they usually need a lot of support to get through it,
Okay, thank you.
You're welcome. Okay, so I see in the chat. Okay, terrific. So I will email this to you, and wonderful. So thank you all so much. love doing this work. This is my email, my assistant's email number, and AmiraCrawfordTherapist.com is the website where you can connect with all of our websites and learn more about all the work that we do. And you're so welcome. And I hope you all have a great rest of your day. And I hope you don't need to use this anytime soon. All right.
All right. Thank
Okay, thank you.
Have a good afternoon, everyone.
You too.
Definitely, guys. Good
Bye,
afternoon.
have a good day.
Bye-bye.
Bye-bye.
Right.